So I want to say right off that what I intend this to be is less about our product and more about a general call for dosimetry and what we'd like to see out of the use of dosimetry, the ways to use dosimetry, and the philosophy of rather than in particular our product. So with that, I'm going to start by talking about a little bit of an overview. This is the history, the dates, of what we've done in dosimetry so far. In 1901, which was actually just a few years after even the discovery of radiation and radium, a couple of doctors used this in direct contact with tuberculosis skin lesions. So I'm going to call that the first brachytherapy. And interestingly, all of this is on the SNMMI historical web page. You can get a list of when all these things occurred, and that's where I lifted them directly. In 1936, a cyclotron-produced phosphate 32 was used to treat leukemia, and it was actually semi-successful, but obviously we don't continue to do that today. But that was our first radioisotope therapy. 1942, dosimetry using radioiodine to treat thyroid cancer really came online. So that's obviously a radioisotope therapy we still use today. It's very successful, and that's why we continue to do it. And it wasn't until another 15 years later that the first
Andy, I'm sorry to interrupt you. Yeah. We're not seeing any slides. Have you changed slide?
I have. I will. I paused my screen and forgot I had done that. Sorry.
There we go. We're seeing it now. Perfect.
Well, it's a good thing I haven't covered anything useful yet. Yeah, thank you so much for making that known to me. So yeah. Anyway, we were on the first external beam radiation treatment happening in 1957, and a year after that, the first scintillation camera, not probe, but actual spatial resolution camera, occurred. So what we think of as external beam radiation, 1957, what we think of as a nuke med department starting in 58, and so on. But all this shows that dosimetry has been around longer than maybe we originally give it credit for. Even if you know about iodine, there was stuff that happened before that. And, this resurgence is of nothing new or whatever. Vocabulary units. So I have this tendency, the whole field has this tendency, and I'm going to try and be very good about it during this lecture, but I need to make that distinction between activity, which is where isotopes are decaying, but how many decays are occurring is activity. The units for this are becquerels or curie, as opposed to dose or absorbed dose, where we're actually talking about how much energy is deposited in the tissue per unit mass, which is gray or rad. So I want to be very clear about that distinction. Sometimes activity and dose get interchanged when they shouldn't, and I'm going to try and be very good about being clear on that. Biological dose is another thing. That one is where we try and take the absorbed dose and put it into some stochastic models to predict what kind of tissue response we're going to get. So there's biology, hence the biological dose in front of it. So sievert or REM, and there's various flavors. We'll talk about those at one point. So here's the overview of what we're going to do. I want to take a look at what was state of the art. This is kind of a historical
Andy, we're still seeing the same screen. I think your screen is not updating again. Sorry for interrupting you again.
It looks like I double tapped the pause. Are you seeing now?
Yes, we can see it now.
Thank you. So I promise not to touch that button again. What was state of the art will be a historical look at what made up dosimetry at different time points, what we need to know and where to get it for doing dosimetry, why calculate dose, and how to optimize using today's technology. Then we'll finish in maybe the most useful part, assumptions and tricks that will help us do dosimetry in general. So what was state of the art? Well, when we started by putting a little bit of radium on some tuberculosis skin lesions, that was fixed dosing. It was basically what they had, and they put it on there. But this has evolved to doing trials to figure out what a maximum tolerated dose for an entire population would be, and dosing some safe amount there, or where efficacy starts. This is the easiest form of dosimetry. It's also the not really dosimetry part of dosimetry, where we just say this amount will always work, give that. The problem with that, it's super easy. It's you can order the dose ahead of time because you know how much you're going to give. You don't have to know too much about the patient before they show up, and so on. There's no prep work to it, and it is what, if you can get away with it, is definitely the favorite of pharmaceuticals to go for. On the other hand, clearance rate-based ones started in the iodine era, so 1940s. And in this case, what we did was we said, look, this person holds on to the isotope a little longer than this person. This person clears really quickly. And they would up the dose for those people who cleared it really quickly. They would reduce the dose potentially for people who held on to it a little longer. And the idea was to try and balance how much dose that person was actually receiving by adjusting the activity based on their clearance. So that really began in 1940 and carried on. Then we started doing actual measurements and trying to do calculations of what kind of dose each organ was going to get. This started a little bit before the 80s, but really came into its own there. And we had things like phantom-based transmission coefficients. So they'd take a standard person model and do Monte Carlo codes, which took forever at that time to run, but they'd tabulate the results to, if you have a unit amount of activity in the liver, it treats the kidney, spleen, and they tabulate that for an entire isotope and keep those tables, and then MerdDose, one of the first software packages to let you put in what you had and look up that table, do the math for you, and generate those doses in about the 80s. So that was kind of state of the art for a very long time. In about the 20 years, in about the 2000s, a few products all came about at about the same time. Point kernel methods were assuming that we know deposition lengths, which we can measure experimentally. We could say, well, if you have a uniform density and we have a point source of activity, we know how much dose is being as a function of distance from that source. And what if we just treated everything like a source and went through there? So in the 2000s, that was a method that was used, and then extrapolated to, well, what if that uniform dose point was actually a voxel shape, and our target that we evaluated some distance away was another voxel? That was the S-voxel method. And originally, like I said, these started in a uniform media, and they have added the ability to be a little bit less uniform in density and media, but that's still their thing. Those were all validated against Monte Carlo. So I've got two dates here. 1980, Monte Carlo was around and it was usable, but it was not fast. And so it wasn't something you could do patient specifically. You tended to do it on a standardized model and then have that model fit your patient. 2005, maybe a couple years before that, really the first attempts at using Monte Carlo directly for a patient in a clinical setting in time to affect their treatment. Papers were starting to be published about that. So this is kind of a timeline of what has been state of the art. It does not mean that once Monte Carlo was available, it pushed X-voxel or point kernel out. It's just these are when they started. We're still using clearance rate based and fixed dosing to this day. So what do we need to know and where to get it? Well, the first one's really easy. There's a huge collection of all of the isotopes decay particles, alpha, beta, positron, gamma, Auger, and their spectrums. You can find these at NIST. You can find them at the Radar Dose website and Oak Ridge National Laboratories. I'm sure there's plenty of others that have these. Those are the ones I usually go to. Once you know that, which is again going to come from picking your isotope, you can go on to more of the patient-specific information. And that would be what surrounding tissue is, what it's made up of, and its density. And here, the most basic way we could do this is an assumption. Like I said with the point kernel a while ago, the first versions, I know they've evolved from there. You could make the assumption that the entire body is made out of unit density water. And you could do that. You'd still be pretty close. You could further refine that and say bone is of this density, lung is of this density, and all soft tissue is unit water again. You can ramp up those assumptions, but each one of them makes the thing a little more complicated. We get even more information, at least in 2 dimensions, from an X-ray, since X-rays are going to attenuate like photons for some odd reason. And so we can use an X-ray to calculate attenuation, and we could then use that to do a better job of attenuation correction in planars. Likewise, we could use recovery coefficients and the like. But the most information we can get would come from taking computed tomography CT and getting that Hounsfield unit, which we can translate to density and attenuation in a voxel format with as fine a resolution as we can get. I would also point out that while technically you get the makeup of data of the material from an MR, and it is a great imaging source, the MR to density is not as straightforward. So it's in the works because of PET MRs, and there's certainly some very leading ways to do it, but I've written CT because it's the most direct. Then we can ask, where do the decays occur? So we've got what is the body made up of. Now we can start saying, where do we get our information of where the decays occur? And that originally came from scintillation counters, not cameras. This would be your Geiger-Müller tubes, something we still can do today. Take a whole body rate from 6 foot or away, or put the probe right up against the thyroid, and we can look at how it's clearing from whatever we're pointing at, right? If it's the whole body. These aren't quantitative inherently, but if you stay consistent with your measurement, they are relatively the same. And so we can get a functional graph shape, and that's going to come back later, but a functional graph shape to try and fit how things are clearing out of a patient, how fast they're going out of whatever we're pointing at. Likewise, scintillation cameras, the planar imaging that we would have now would be the equivalent of that. But even when those first started, we would be able to now add some spatial refinement to where that activity is. Oh, look, this is in the liver, not just the whole body. And we could define organs. That's certainly still a very good method. But again, the most information we have is the voxel at this time, and that comes from computed tomography, either PET or SPECT. And as the next series in the lecture we'll talk about, SPECT can now be done quantitatively. PET, of course, has been being done quantitatively for a while. That'll be next week. What we need to know, and now I'm going to call it when to get it. So we've covered where. Now we talk about the time component of these. And the first one that I'm going to go into in the next slide is compartmental models. These are numerical equations that you can solve. It's a huge partial differential equation. Depending on how complex you made it, I made it semi-complex. And that helps us figure out where the pharmaceuticals go, and by pharmaceuticals, if they're randomly distributed with activity, the activity. We can do probe readings like we talked about with the scintillation tube. We can do planar imaging like I talked about with the scintillation camera, and of course volume imaging. And we'll talk about these as we go further, not maybe the probe or the volume, because they're ways of looking at from the other ones. And then determine where the energy from each decay is deposited. And this is the first time now on slide 5 where we're talking about energy deposited. So this is finally getting us to dose instead of activity, but all of it was needed to get there. We could do this with something as simple as deposition lengths, which is an analogous to the point kernel method. Over on the right hand side here, I've got my alpha in water. If you come in with the decay product of whichever one is you're following on the graph, you'll see that it deposits energy, peaks, and then drops off and drops all of its energy. There's a different shape for different kinds of particles, so neutrons, but electrons, X-rays, and of course you see the protons again. We could just use that and say, well, it's this far from the source. Here's my distribution out to this, and convolute that over a volume. That would be a way, but we could also do Monte Carlo, which uses this as an information. We take a random roll and see whether an event occurred, and we deposit or not deposit the energy as it walks its way on a path through the person's anatomy. And the S values and point kernels, of course, also do similar ideas, but indirectly. So I said I'd talk about the compartmental model. I don't expect anybody to write this down. I just wanted to show how complex this could get very quickly, and it lets me show you what the idealized curves are going to be on the next slide. The idea here, if you look at the picture, is that the body is where we're going to put all of the pharmaceutical, which will be radio labeled, but we'll talk about it as a pharmaceutical alone for a second. And that can go to anything it touches. So the body is touching the liver, the kidneys, the bladder, and out. Likewise, the liver can receive stuff from the body. It can pass things to the kidney. I mean, technically it could go the other way. It just doesn't. Kidneys to bladder, bladder to out, and so on. And these equations show that the total at any given time should be equal to the injected amount times the decay, physical decay, because we did label this in this point, and all of that, all of the other value, all of the bodies in here should add up to that total amount. And then we can talk about the change in the body is going to be the original, the change in the body is going to be how much it gives up to the liver, how much it gives to the kidney, how much it gives to the bladder, how much it gives to, well, sweat in that case, or urine, but outside of the body. And so all these equations you start solving for, and you get solutions that look like this. On the left, I have the start where all of the injected activity goes into the body. Hence, we start at 1. It's not yet uptaked in liver, kidney, or bladder, so they start at 0. And we get these kind of curves. So the contribution from the body to the liver ramps up, and eventually the liver gets to a state where it's receiving less than it's giving to the organs downstream, and it starts to decay as well. Now, again, this one on the left is just the chemical contribution. This is not activity. This does not, if you sum all of these at any given point, you should end up at 1. That's the concept anyway. It's worth noting that there is like this hill that we climb, we get to the peak and we come over. It's also worth noting that those peaks are not in the same place. So here is my liver peak, here is my kidney peak, and way out here is my bladder, which whatever. The only thing that's constantly increasing is out because it doesn't give its activity or its chemical to anyone. So it just accumulates. If we multiply this by the physical decay, which is now the equivalent of labeling our chemistry, we see that it shortens, it reduces, and if we were to add any of these, we would just get an exponential decay. So again, I say that to talk about some of those tips and tricks. I had to throw that out there. Excuse me a second. Too much talking. All right, planar segmentation. I wanted to show this as well. So what I have here is actually 4 time points. This is a lutetium whole body image. And I've drawn the segmentation out, and then I've done that on all 4 time points, and I follow the geometric mean of those volumes through time. And the graph on the right shows what we're getting, and it's probably worth noting that in this planar segmentation that I've done, everything is decaying. So in the previous one, we saw that we should have this uptake followed by a decay, and yet our measurements on this with a 4-hour delay show nothing but decay. And the reason is we're on the downhill slide. This is lutetium, which is really lutetium dotatate. It does do a really good job of binding to its organs where it's supposed to. Of course, it has a little retention in the kidneys and spleen, but they tend to clear rather rapidly. And so that uptake curve from the body to the lesion, the body to the liver, is very quick, followed by really just decay. So this is a matter of we missed the climb up, and whatever will we do about it? But this is the decay only scheme we're seeing in there. And I'll get to what we do about it after this. So this is where I want to say, why do we even calculate dose, right? What is that purpose? And there's an immediate reason for it, and there's a future one. The immediate one is effective treatment of tumor without endangering patients. We talked about scaling the dose in iodine with the idea that we could give more in order to give the correct amount of dose. If we gave the same amount to everyone, people who clear really fast might not receive as much treatment to the tumor that we're trying to attack. For people who clear really slow, it may stay in there too long and damage an organ that wouldn't have in the general population. And so we want to do dosimetry largely to really tailor those. The radioisotopes that we use still to this day, the historic ones that have lasted through time, have done so because they have been ones that were pretty hit or pretty always hit, not even hit or miss. When you give the dose, they bind exactly where they're supposed to bind, they stay there, and they don't go elsewhere very much. We've got new radiopharmaceuticals coming online that might require they might be a little closer to give the right amount of dose, or give the maximum amount of dose that we can give to the patient without endangering organs, in order to get an effective amount to the tumor, because the binding isn't quite so strong or straightforward or long-lived. So we might be able to bring new drugs to the market if we're giving the right amount when we determine whether they're effective or not, and that comes from doing dosimetry. The more future looking thing is to say that we can understand and provide more data points for future models. There's models out there, I'm going to talk about a few now, that are really trying to deal with the shortcomings of what we can say for a dose. And when we go to fix that, what we need to do is fit parameters. We don't have enough data to necessarily do that. An example. Equivalent dose is where we scale alpha decays because they're better at killing cells than the same amount of energy deposited from a beta. And so, what scale we give those alphas has been argued in paper after paper. It's gone everywhere from 2, maybe even sub 2s to 20. And it seems like it constantly is being moved around. And it's just because we don't have enough data to really nail down where it should be, and in which situations it should be. There's also other factors that need to be taken into account. Tissues vary in sensitivity, repair rate, and repopulation. So we've got this effective dose where we say, okay, let's say you're giving a uniform dose. The first organ to really care is going to be the kidneys, more than likely. There could be something else, depends on the radiation. But the kidneys don't really repair themselves once they're injured. They tend to stay that way. So we need to make that a very sensitive organ. Let's weight dose to the kidneys pretty high. Let's take something like the liver, which can repair, and do that fairly a little bit lower. And so not only in uniform radiation across the body does this matter, but if you're actually now changing the proportions that you give to different organs, we want to change those values to talk about in one number, what's the chances that this person on a whole will experience some form of toxicity. And so that's what that's for. But again, how sensitive are those? What should be the right weightings and values? They move around every once in a while because we need more data to know where that line really is in the general population. Cell damage is proportional to energy deposition, but it's not linear. So the fact is, if we give a lot of energy really fast, that tends to be better for the numbers of cells that it kills. If we give a long fractionation, however, we tend to reset the repair rate. And so that has its advantages too. What is the biological fit of that kind of energy rate that we're giving? That's tried to be answered in the radiobiological effect. These require more parameters, that we need good amounts of dosimetry followed by what the outcome for that patient was to look at where those fit. I'll finish off with something that's not necessarily a model, but a reason why we need them. And that's to say that the highest resolution cameras that, that I have access to anyway, one voxel is still on the low side, 1.8 times 10 to the 9th cells. That's a 0.6 by 0.6 by 5 centimeter volume per voxel. And so we're going to need stochastic modeling in order to do that, because we're always going to be averaging over a very large number. How do we optimize to today's technology? Well, we want to utilize quantitative, volumetric, high-resolution images. We have quantitative SPECT and PET cameras. We have higher resolution CTs on those cameras these days. And so it would be great to utilize those to get the most information about our patient as possible and where they show up. We want to follow suborgan structures and maybe even down to the voxel. Current methods may include, doing what is the dose to the kidney on average, but what if that's all stuck in the cortex? Or, there's these suborgan structures that we could look at, whether they vary across that, whether they're useful or how important they are. Make sure that we're dosing not all in one spot and then averaging it over a whole organ and overdosing the cortex, but the rest of it was fairly low, and so it looked like a mean dose, not very big. The best way to do this would be take the smallest amount of information or the smallest structure that we can get, the voxel, and then combine those variabilities into the suborgan structures that we want to define, or to the whole organ. Or the nice thing about having a dose per voxel is we can define whatever we want to for the volume we're evaluating. We also want to utilize the patient's CT to define the density per voxel so that we're dealing with their anatomy and not some stand-in. We want to employ faster hardware to make Monte Carlo nearly real time. All of these are things we can do and have done. Analyze absorbed dose in ways to account for variability. And that's at this point, we're talking dose volume histograms and some of these stochastic models. But we need to continue to really refine those and then pursue the dose response prediction. And that's the grail here, because if we could get to the point, radioisotope therapy is expensive. If we can show that we can give it to the people for whom it will work, that expense becomes less of a concern. If we're giving it every time and hoping, then it starts to become really dependent on how many times it works. So we do want to try and find a prediction on what that treatment will end in before we give it. And that's what dosimetry hopefully should be our big goal here. just to show you, like I said, the Monte Carlo dose map here. I've designed, drawn the kidneys in this case, and we can look at this and we can say, aha, so I'm fairly uniform. The steeper this line is, the more uniform it is, but you know, I can say that the kidneys, almost every voxel has received less than 1 gray, and we can parse this out to really take apart what values we have, what distribution we have. And this can be fed into all kinds of other algorithms beyond just what the dose, absorbed dose is per voxel. All right, now to the part that's maybe a little more useful instead of all being historic and setting the precedents for it. And I apologize because this is actually fairly short. I wanted to point out a few things though. I've brought back our solution, our numerical solution to the compartmental model to talk about how to make time point selection when you're trying to figure out when should I take a picture, right? And freeze frame. I will say the ideal, which is not feasible, would be to have a time point very low or assume 0, and then try and have a time point at the peak of every organ, which is something you don't know and you're trying to take a measurement for, but it will statistically be pretty close. So again, ideally, we'd have a lot of time points. We'd try and hit the peaks of each one of them, and that's a lot of time on the camera for the patient. It's a lot of cost for the acquisition time and whatever. It's probably not likely that we'll get that many points. What instead we can do, I've taken the worst case scenario here, which is the body, and I've shown you as a function of time what's its cumulative activity. I made this easy on me. My dx is 1, and I've got e to the minus 1/5 over times t. So we know that the asymptotic value of that is 5. But we see that even in the first short amount of time, we've reached half of the given value. And it follows this half-life because it is an exponential. We asymptotically do get to 5, but we need a long time to get there. What I'm saying here is that while it's important to get that early behavior if you can, a huge amount of contribution comes from getting the long-term behavior correctly. So if we can fit the downslope side, we get a huge chunk of it. Then we can hide what we don't know here in making very good approximations for what it fits. So if we even do a trapezoidal rule and we're somewhere here on the curve, the trapezoidal rule still gets 80% or more of what we saw, and we can fit accordingly. So just as a point here, you know, again, this is to help you visualize where the curve fit needs to be right in order to get the most information. In the worst case scenario where there is actually 1 at 0, you've got a huge chunk coming up at first, but as we do these curves like this, it shouldn't be nearly as sensitive. I also want to talk about a trick that I don't see employed enough when considering doing imaging physics dosimetry or imaging dosimetry. And that's the idea that when we go to do a curve fit for these things, there's actually, it's good to think of it as 2 parts. One of them is that I could have a non-normalized relative function shape that I can get from representative samples of organs. And I do those representative samples because despite the fact that I managed to find one where there isn't a whole lot of organ overlap, that's very rare. If I do the whole liver and I'm also including some right kidney in that, my organ clearance rate is now a convolution of liver and kidney. Likewise, you know, kidney and liver when I go to do the other. So if you are going to figure out what that shape of the curve is, it is maybe best to have a representative sample of just liver, just kidney, and not the whole liver or kidney. When you need to find out what exact quantification that goes through, you really now only need one time point. You've got a shape of a curve. If you have one time point with good quantification, you can go through that time point and inherently have, you know, a good representation of magnitude as well as shape. Representative for shape, whole thing on a good quantification for that one time point for magnitude. Another thing that gets overlooked, and I get asked a lot, but when we're doing imaging-based dosimetry, when we're taking it from what we can observe from these cameras, we are inherently being ligand agnostic. And the reason for that is if we consider what our effective clearance is, what we're able to observe, that is a combination of physical decay for sure, but it's times biological clearance. And what affects that biological clearance is, well, a couple of things. It is what the ligand is holding on to and how well it's doing so, as well as the chemistry of should that isotope break free after, where does it stay? So we've got chemistry all in this biological clearance portion. And that's ligand specific. That's where our ligand specific information comes from. But I'll do these presentations occasionally, and I'll show this with a lutetium dotatate, and I'll be asked, okay, but what if we want to use dotatalk? Still lutetium? Yeah. Like, okay, well, it's going to be all in your observation. We're going to deal with it. It doesn't matter what the ligand is. So I understand thinking these are variable, and they absolutely are, but we're dealing with that variability through measurement. I'll get through the assumptions, and then we're almost to questions. I want to point out these because traditionally the assumptions that we make are what we need to improve in the future to keep stepping forward. I will acknowledge that the uniform dose distribution is the assumption we're making in a voxel, and we know it's not true. With 1.8 times 10 to the 9th cells in a single voxel, we know that, you know, there's going to be some distribution in that. And again, with measurement, we can kind of do our best to figure out what kind of effect that has. Partial volume effects are in play if what we're talking about is a single voxel. I kind of talked about this already, but it's less when we add these organs in a sum. We take those partial volume effects and spread them out. We kind of let them cancel each other, if you will, if the organ is big enough. So dose distributions, you know, they're going to have some outliers, but if we look at their effects on whole, we really get rid of those volume effects. We have more to learn from radiation oncology. The external beam people have been doing this for a long time, and while it is a big chore, I'm not saying it's easy to design these beams correctly. The outcome to those beams tends to be very, very uniform distributions with a fixed dose rate. And so they can really fine tune what their dose being given is. That's given them the ability to really figure out what these, and they do a lot of them. So they've got the data points they need to really figure out what the effective dose rate is, fractionation, and we need to take those that they've learned and apply them to what we've got in order to move forward. I will say that I think the assumption is that the real best treatment for any patient is combine the beam for big, large bulk tumors that radioisotopes can't get into, but they know where they're at. We shoot them with a beam. Pharmacology, you know, chemotherapy is always going to contribute, but then radionuclides, we can go get those micromets and we don't need to know where they are. That's our strength. People have combinations of all of these, and if we can get ourselves to play together nicely with beam physics, with you know, a whole treatment plan, become part of it, we can get better outcomes for our patients. So that's it. I thank you guys for your attention. I'm ready for questions. I will say before I do that the next in this series is going to be given on SUV SPECT reconstruction and its use in unifying multi-center trials. Helena McMeekin will be giving that, and I do encourage you to come to that one. We are figuring this out. There will then be a 1-week break at least. You will be notified after that one, where we figure out what we can do to bring this to a larger audience and refine what you guys want to hear. We were just doing ones we had available for the first ones to begin with to start this off. So thank you for your attention, questions. And if the question is, my email address is here on the bottom. If your question is not related to dosimetry, but Hermes in general, there's also info@hermesmedical.com for all your non-dosimetry questions. And at this point, I'm going to mute myself for a second and take a large drink that I need, and then we'll start answering questions.
Thank you so much, Andy. That was great. If anybody has a question, please could they type it into the chat, and we will ask Andy one by one. The only question that I see so far is one about whether the slides will be available after the presentation. We have made a recording of this, and we are still recording now to get the Q&A. And we will put that up online, so that will be available afterwards, and we'll let you know how to get that. Yeah, there we go. Okay, I see a question already. Andy, are you okay?
Yeah, I'm ready.
Okay, so we've got what dose algorithms are used in Hermes, and where are the DPKs coming from?
What dose algorithms are used in Hermes? Yeah, so we actually have two that were covered as two separate products at this time. The first one is we do have a voxel level dosimetry where we use Monte Carlo on the fly. It takes less than a minute to calculate these doses now. That is the one I'm most proud of. But because that also requires imaging that's kind of hard on the patients, we also are maintaining, growing, and constantly improving, I hope, our organ level dosimetry, which is Olinda 2 based. It's organ level phantoms that stand in for our patient, and we just need to figure out how much cumulative activity occurred in each organ to feed that, and it gives us a dose answer. So both of those are what we're using. Those are the algorithms for that. The DPKs, of course, are coming from our voxel level dosimetry.
Thanks, Andy. So the person that asked that question, Kirov Asen, did that answer it? If you'd like to unmute yourself and just to confirm that. Okay, maybe not. Okay, we'll move on to the next one. If you have more questions, please please continue typing. So the next question, can you see these, Andy? Are you looking in the chat window?
I am.
Okay, great.
Which helps. Thank you. I'll go ahead and answer the next one I see is, why do the highest resolution cameras only have 0.6 by 0.6 by 0.5? They probably don't. There's probably higher resolution cameras out there. I was thinking of SPECT when I had this. I know there's probably higher resolution PETs. There's probably higher resolution specs. And that's why I said the ones that I have access to. I probably shouldn't have said that's the best. I should have said that's what I know. But yeah, those are any good resources for basic and practical dosimetry for nuke med physicians. A lot of physics stuff really goes over the head, but I need to identify areas that are important for physicians to know and required practically. I will say that radar dose gets to be a little bit high in the physics side of things. It does have the distilled versions in there as well. SNMMI has been putting on some dosimetry seminars. I know that addresses a US crowd and not a European one. I apologize. I know the area I know. Helena might be able to speak to resources in the UK and maybe some in Europe. I will say that those SNMMI ones, if you can find your way to them, are amazing. What they do is they pull in physicians who are doing dosimetry in their areas, doing radioisotope work, and ask them what are you facing, and have them give lectures like this. So if that's an area of interest, I know this Hermes Educational series is also looking for topics, and we might follow suit. We'll see. To be announced, but I would say that's the best resource at this time that I know of, and we'll try and put together something if there's enough interest in that to address it that way. I acknowledge this was a bit concept and physics heavy and not so much practical, but reach out to us. We have that practical knowledge too. I was trying to make this entertaining as well as informative, and maybe didn't focus on the practical aspects as much as we could have. All right, so
Thanks, Andy. Just while you've taken your drink there, I can see there's a nice comment from Mark, who says that the ENM organises dosimetry courses regularly, but the next one is next year. So hopefully that might provide some more information for the European crowd.
Mm-hmm. The next question, well, I'm getting through this one from Ashwin. Oh yeah, that's that one. So the next one from Arda, voxel based. Does it have to be individual voxels or similar voxels? Can it be separated and treated together to speed up Monte Carlo code? Absolutely. You could convolute your resolution to speed it up, but I would say that a full body, a large view, multi-bed spec done over 3 time points at this point is still sub-minute. When we look at what we're doing for patients, very few of these do we have the patient on the table, we inject them, and we need to know that answer for what it's given in the next 5 minutes. It's usually at least overnight before we would give that, which is a complication of the camera not being able to tell the difference between the injected sentinel dose and the therapeutic dose. So I think the time frame now is fine, even with the higher resolutions that we're talking about. Certainly that has only become true with good hardware recently, but you absolutely can convolute those voxels to be fewer. That will speed up the time. I just don't know how necessary at this time it is. And if I answer your question and you feel you need to,
thank you.
You got it. Good. So for Mark, how relevant is dose volume histogram when it doesn't take functional status into account? A voxel over a stem cell or glomerulus is different than over a stroma, and that's absolutely true. Dose volume histogram is not by itself the end-all be-all, and I concede that entirely. I think the most information we can get out of a scan like this time is probably starts with dose volume histogram, and it will be the constituents of that dose volume histogram, aka dose and what belongs in a volume, that we can run further texture analysis, decay rate. All of those things start with having that distribution, the most basic representation of which is a DVH. So I agree. I don't think it's the end. I think we need to continue to go on it, but it is the base unit for which the rest is derived. Also dose rate, which we can do with a DVH of each time point as a dose rate, right? We know how long one image was acquired for, so we know how much activity occurred in that time frame. That's a rate. If we do a dose for the duration of that scan, it's dose per duration of scan. We have a rate, and if we do that for each time point, again, since these things are sub-minute to calculate, we could have one for each time point that gives us information on the voxel level for dose rate, which could give us the potential to do more of these calculations. But it absolutely true. Is it possible to use PET images for voxel dosimetry? It absolutely is. We can certainly do organ level right now with it. The ability to do PET as the imaging component is possible, and then if you follow it up with the same chemistry but a different isotope for therapy, we can do that, and we're working on the voxel level with PET. We just have to validate the annihilation and the switching over. So to be announced, but as of right now, our software doesn't do it on the voxel level. We're working on it. It is for spec, but we can do it with organ level dosimetry, and certainly done with PET. Will there be a practical demonstration on the actual use and stability of the latest Hermes dosimetry tools with some example from the clinic? It won't be in this talk.
Perhaps I could take this one, Andy.
Yeah.
We absolutely love demonstrating the Hermes software, particularly dosimetry, but it's probably better to do that on a one-to-one basis or one to just you and your colleagues, so that you can ask your questions rather than over a webinar. So if you would like that, then we're very happy to do that. Just get in touch with us individually, and we will take that forward with you afterwards. You back in, Andy?
Yeah, I was reading. So what types of kinetic models are available in Hermes? At this time, we do trapezoidal fit to a certain start, and we do fit with exponential or bi-exponential decay in our models. There is a triple in Olinda, triple exponential model fit in the EXM part of that, which we are the distributors for. And we're working to implement more. Obviously, these uptakes that we showed in the compartmental model are not represented by a bi-exponential fit, or an exponential fit for that matter. But again, that's what the trapezoidal rule is for currently, and we're working to increase that. There's also a few kinetic models. We don't do a compartmental model. There are people who do that really well. But what we do have, like I said, is a trapezoidal rule, and B, there's the ICRP 30 hat model in Olinda, and there's also the voiding bladder model. So I know those aren't probably really what you were asking, but those are the other ones we do offer. Any useful tips to calculate a dose range for organ level doses? This can help guide you between likely min and max, even if not an accurate multi-time point spec. Absolutely. Is to calculate. I apologize. Yes, I completely agree. I apologize. I misread it. Jacqueline does point out another really good useful tip there. Sometimes it's easier to have a high and a low range where you make all the errors that give you positive and all the errors that give you lower, and give yourself upper and lower bounds. And that is something I encourage always, but I also encourage specifically one area where that really comes up is like a surgical resection of a kidney, being able to calculate it with the one kidney and then doubling that because the model requires that you put the activity in the kidneys. So, for a shortcoming of the standard model of a person is that they may not match your person exactly. Do a doubling of the activity in order to get that concentration in the left kidney, if that's the one they still have, correct, and then do one with it spread out to get so that you don't overestimate the dose to the others, and it's somewhere in between there. One example of many for how to do a high and low value. Which isotope is currently validated for Monte Carlo? Oh, I know we've got gallium. I know. Is Auntie actually in here? Auntie would be exactly the guy who
yes,
can answer that better than me.
Can you hear me?
Yeah.
Yes, we can hear you.
So it's the gallium 68 iodine, indium 111, the 2 iodine isotopes. Then it's the technetium Lu 177 and the yttrium 90. Those are the validated ones. And there was a question about the can you do voxel dosimetry on PET images? You can with the gallium 68 and yttrium 90. We have tested, and it seems to work quite well.
Oh yeah, I did forget about those. Thank you. This is why you call in the expert when you got the ability. Huh? Thank you, Auntie, very much. Jacqueline made another comment about even making an assumption about mass can be useful, and that's something that is built into our program. If you draw a volume of interest over the liver, we will change the mass for that organ in the Olinda run to reflect the mass that you've defined in your volume of interest, because absolutely that is the first step in doing patient-specific dosimetry with Olinda. You can make those mass changes, and then since energy deposited over mass is dose, you've made a huge change that's more accurate to your patient if you correctly measure the masses for those patients. Are there any animal models incorporated? So this is kind of a loaded question. Yes, but why do you need them is the answer. I understand the reason for animal models, so that question sounds harsher than I mean it. If what you're wanting to do is translational medicine, where you say, I've done a study in a mouse or a rat or a beagle, which are the 3 kinds of animals that exist in Olinda. Non-human primates to come, I hope, sometime. But they are not there yet. Those 3 exist, but they are for calculating what the dose is inside of that mouse, that rat, or those beagles. It is not translational, where we do the conversion to say we expect this concentration in a human to follow that the FDA has required. So they are in there. There are those 3 models, but they are not set to automatically do translational medicine. They are meant for actually identifying those models. Could Hermes be used for tumor dosimetry at the voxel level? Absolutely, and that is the point. I may have done myself a disservice by only defining the kidneys in my region, but I could have drawn over the tumor. I should have drawn perhaps over the tumor, and doing so would give me that same information about the tumor. In a presentation with this many people, if I draw the tumor, I always invite myself to, why did you include this section, or why didn't you include this? And I didn't want to make myself available for those questions. So if I'm being honest, if we wanted to show that, again, reach out and we'll do individual, and we can do whatever you would call the boundaries of the tumor and show you that. Does the MC transport electrons and photons? Oh, Auntie, you want this one? Again, I can tell you that it does electrons to a cutoff energy. Then I'm going to let Auntie, because photons to a cutoff energy.
Yeah, it does the full Monte Carlo on photons, and then the local deposition model for the electrons.
And we've got papers that validate that for the isotopes we've used, local deposition to the electron is a valid assumption to a very low percentage. But offhand, do you have input on like what that would be? Auntie, sorry.
Oh, sorry, I lost the
yeah, the question was, do you remember on the publications what the percentage of difference between full Monte Carlo and our worst case scenario of local deposition was? It was remarkably close, right?
Yeah, it depends on the isotope. The biggest difference was with the gallium-68 and yttrium-90, and it was below 10% even with those.
Yeah, that was our worst case scenario. So I think, right. But we do evaluate that before we bring it out, and we've got the papers where we evaluate full Monte Carlo versus local deposition. Last question is, what is the minimum Monte Carlo voxel size allowed? And unless someone tells me differently, Auntie, but and I believe it's really just limited by what your CT and emissions study feed it. I don't,
Yeah, exactly.
yeah.
Yeah.
I don't think there's a inherent minimum size.
Sorry, it's Gianni from Italy.
Yeah.
Hi, Andy. I have a question. It's regarding, I think that is related to the last question. I would like to understand how big, how much is the voxel. You say during your presentation in why calculate those high resolution camera that was 0.6 by 0.6 by 5 centimeter voxel.
Yeah.
So this is the voxel volume per SPECT and PET camera as well.
Again, I was using a that is not to be like this is the only size we accept. Okay, I want to be very clear. I was saying that if I take what is a semi-average voxel for data that I had, the first data set I looked at, that was the size of the voxels that I had available to me, and then I used that and the knowledge that it's about 10 to the 9th cells per cubic centimeter to give you just, it was only to set an idea of just the number of cells that one voxel still represents. Those sizes should not be taken as this is a limit or this is the recommended size or anything. It just happened to be, I was trying to get that times 10 to the 9th value to show just how many cells are in one voxel still, and I chose that. But it's not a definitive limit or suggestion or anything else. It's what the voxel size of the camera I had was.
It's clear. Thank you.
Okay, and in the case of metastases, there are a lot of lesions. What is the best way to do dosimetry calculation, and which lesions should we start, from the biggest to the smallest? Well, I would say that we have a product and more coming that are going to allow you to identify areas that you would consider a lesion easier than even what we have now. And then you could evaluate those independently. Anything you can segment, you could evaluate. As far as best practices on doing that, I would say yes, absolutely. Go biggest to smallest. It would be ideal if we could have also a total tumor, but based on MTG, we would be able to define what is a tumor worth following, eliminate anything that isn't really a tumor, like bladder uptake or whatever that might trigger that being too far, and then evaluate the mass on whole as well as the individual lesions as we split them out. But I will say that that is something to be determined. We definitely want to follow the biggest tumor. We want to follow the fastest growing tumors. And ideally, we'd love to do them all, but a lot of times that's not very practical. So I would say the biggest and the fastest growing are certainly the ones, the same thing that you're following now in PET for, when we're using PET completely as a metric for how tumors are going, when you pick a lesion in that to follow, you're doing that, and then whatever is going on, beam or chemistry, chemo, whatever, you're following those. That same guideline goes for dosimetry. Pick the tumors that are of most concern to you and evaluate what they're receiving as well as their outcome. Hey, I caught up. That was the last question we've got, I think, unless I've missed any.
I think we're good.
Well, like I said, thank you to everyone. I will go ahead and I'm going to stop the recording here in a second. After I say thank you for attending, I believe there will be, well, I know there will be another session next week at this time. And again, Helena, you can tell them the topic line exactly because I don't have it in front of me. I encourage you to attend it. Then we will take a little time and we'll redo this in short order. We won't wait very long, but we're going to take a little time to learn from what we did, how to get more people in here, how to set it up a little clearer, and start taking suggestions perhaps for topics that you'd like to hear. But for the inaugural one, I really appreciate everyone's interest, the questions, and being so respectful. It has been very nice to have you here. And I'll let Helena tell her one and then.
Oh, that's a perfect ending, Andy. We'll send out more information over the email, so keep an eye out for that.
Have a great day, everyone. Ending the recording. Good day.
Thank you, everyone.